Hi, good evening everybody. Pradeep Pendiala, Professor of Anesthesiology, your buddy. Friends, today I'm going to talk about nutrition in ICU patient, intensive care unit patient. Friends, it could be enteral feeding or it could be parenteral feeding. Now let's think about if there is critically ill patient who is on 2 or more vasopressors or inotropes in high doses. If you want to feed them enteral feeding, it may not be safe. Why? Because they are at risk of developing complications such as gut ischemia, and it may get worse or worsen the situation by initiation of enteral nutrition. So better avoid in such cases. In hemodynamic unstable patients, enteral nutrition should be initiated only when the patient is on stable or declining doses of vasopressors and adequately volume resuscitated. Friends, clinical monitoring of gut functioning should be started early when the patient is hemodynamically stable. Once the patient has been fluid resuscitated and stabilized on declining doses of vasopressors, enteral nutrition may be started. Enteral nutrition should be administered within 24 to 48 hours once the patient is stable with vasopressor. Friends, it's very, very interesting, this topic of nutrition in ICU patient. Nutrition status of malnourished patient can be assessed by subjective global assessment, that is known as SGA. Initial monitoring of nutrition intervention must be done on daily basis and nutrition plans should be modified accordingly. It is imperative that nutritional assessment is done by well-qualified and trained nutritionists preferably. It is desirable that nutritionists to critically ill patients ratio should be maintained at around 1:15 or 1:25. That's wherever feasible. Facilities of nutrition assessment will require good coordination between intensivists and nutritionists. Let's talk about energy protein requirements in such patients who are admitted in ICU. Friends, diagnosis of illness and severity and nutritional status and treatment of critically ill patients can influence the energy expenditure. There is always uncertainty. Predictions based on anthropometric or minute ventilation are not always accurate. So you have to be very careful when you are planning nutrition. Both underfeeding and overfeeding are not desirable. Underfeeding and intolerance are often reported in critically ill patients, especially on enteral nutrition. Enteral nutrition can cause infectious complications. That is the biggest problem in enteral feeding. Overfeeding more than metabolic demand is detrimental, always. Most of the patients in ICU, their metabolic demand is very, very low. So overfeeding could be very, very harmful. Aggressive feeding during initial days of ICU stay can be harmful. Aggressive nutrition support signals the body to halt its compensatory mechanism. Feeding should be tailored as per the patient's requirement. Protein requirement, it should be very, very clear in your mind, is normally in critically ill patient 1.2 to 2 grams per kg body weight. Similarly, calories. How do you calculate calories? Calories should be 25 to 30 kilocalories per kg body weight per day. In severely hypercatabolic patients such as extensive burns and polytrauma, ratio of kilocalories, nitrogen balance should be 120:1 or even 100:1. That's the thing. By the way, obese patients, adjustment in calories and proteins must be done on the basis of BMI. Normally, it should be on the lower side. Recommendation for critically ill patients with acute kidney injury is totally different thing. And everybody talks about Harris Benedict tool, but it may not be suitable because I think it's time consuming and overestimation of the energy requirement can happen. I may be wrong. But weight based equations are preferred for energy protein calculation. Friends, enteral nutrition is preferably recommended over parenteral nutrition. When the choice is given between enteral nutrition and parenteral nutrition, go for enteral nutrition. The route of nutrition delivery determines the effect of nutritional intervention. Enteral route could be can cause intestinal microbial diversity. Enteral nutrition has limitations in acute disease phase and gastrointestinal dysfunction. In contrast, the nutritional requirement is better secured with parenteral nutrition. But problem is hyperalimentation, hyperglycemia, and infectious complications remain the key challenges in parenteral nutrition. Enteral is much safer in that way. Always consider enteral nutrition over parenteral nutrition as far as possible, unless it is contraindicated. You can try even combination of enteral and parenteral nutrition. Talking about tube feeding, it's very interesting. My own mother was on tube feeding for almost 2 months during her last days. So I know quite a lot about this tube feeding. And patients with functional gastrointestinal tract who cannot have enteral feeding at all or who cannot eat, we have to try tube feeding. Enteral tube feeding can be done with nasogastric feeding or nasojejunal feeding. And interestingly, nasogastric tubes and some patients may not tolerate gastric feeding in case of delayed gastric emptying and poor intestinal motility. Such patients may benefit from postpyloric feeding. Nasogastric route should be the first choice of enteral feeding when the choice is given between other things. Jejunal route can be used if at all required. Continuous formula feeding with pumps or gravity bag can be preferably done by a fine bore. We must always consider nosocomial infections when you are giving for long tube feeding. Microbial safety has to be thought about. Long-term enteral tube feeding with elemental diets is one of the common but relatively unrecognized risk factors for the development of Clostridium difficile colitis. The contamination and batch-to-batch inconsistency are more likely with homemade or blenderized feeds. You must know something about blenderized feeds. Maintaining the microbial quality of hospital-prepared blenderized feeds within the standards is very important for safety of the patient. Various factors for bacterial contaminations or handmade formulation include unhygienic conditions, food making process or devices or blenders, not blenders, and hygiene of the floor and air conditioning can cause nosocomial infection, mostly due to negligence of the kitchen staff and nurses by ignorance or by their own mistakes. These issues should be particularly evaluated in ICU patients. Scientific formula feed should be preferred over blenderized feed when choice is given. Whenever feasible, closed system ready to hang formula feed should be preferred. Blenderized formula are more likely to have bacterial contamination, as I've just mentioned. Hygienic methods of feeding is very, very important. So, could we have underfeeding? Yes, overfeeding is less likely to occur than underfeeding in ICU patients. But in critically ill patients, underfeeding is generally not recommended. However, patients having feeding intolerance can be underfed. Furthermore, when the BMI is, as I just mentioned, obese people who are having more than 30 kg per square meter BMI may be given less feeds than the metabolic requirement. So this is that, friends, intentional underfeeding can be restricted to specific conditions as just mentioned, like obese patients and such people. Monitoring tolerance and adequacy is very, very important whenever we are feeding. And there is something called gastric residual volume. Normally up to 500 ml of gastric residual volume should be used as a cutoff. And what is this all about? GRV monitoring can be done every 6 to 8 hours to keep the cutoff period amount around 300 to 500 ml. GRV should be measured by syringe aspiration rather than suction pump. So GRV of less than 300 ml can be preferred. And prokinetic agents such as metoclopramide, Reglan, or Perinom, and also erythromycin, interestingly, are recommended in patients with intolerance and risk of aspiration. We have to have knowledge about enteral formula and selection of appropriate enteral formula. And blenderized tube feeding formula is typically prepared at kitchen by blending food or meals into liquid feed. So the blenderized tube feeding may be completely prepared from homemade food or a combination of food and standardized formula. Enteral nutrition can be initiated with the standardized polymeric formula. Standardized polymeric formula feed should be recommended in critically ill patients. Inconsistency in nutritional diet and level can be avoided. Routine use of specialty formula feed should be avoided. Enteral feeding can cause diarrhea. That's a $1 million question. Diarrhea is commonly observed in critically ill patients. Physicians are confronted with myriad of definitions of diarrhea. Do happen, but the $1 million question which I just mentioned, should you stop feeding, enteral feeding when diarrhea occurs? No, enteral feeding should not be interrupted in the event of diarrhea. Feeds can be continued while evaluating the etiology of diarrhea. Now, a word about fiber containing formula or small peptide semi-elemental formula in divided doses over feeding to the patients of ICU is very important with persistent diarrhea. So, you have to exclude hyperosmolar agent intake and Clostridium difficile infection. Routine use of probiotics across in ICU patients is not recommended. However, probiotics should be used only for select patients. Micronutrients has its own importance, which can be underestimated. Pre-existing micronutrients deficiency should be evaluated and assessed. Patients on formula feeds may not require additional micronutrients in the form of vitamins and trace elements if they are on complete and balanced formula feeds. Micronutrients can be supplemented in the patients on blenderized feeds and those on parenteral nutrition. Immune enhancing nutrition, inflammatory or oxidative stress responses have to be considered, and Nutrients such as fatty acids, selenium and omega fatty acids, selenium and antioxidants, immune modulating nutrients may be required and they will be given. Patients suffering from traumatic brain injury, TBI, and adult respiratory distress syndrome may be prescribed immune modulating nutrients. Glutamine supplementation has been shown to reduce nosocomial infection. So, what is this immune modulating nutrient? They should not be used routinely in ICU patients with very severe illness and not tolerating more than 700 ml of enteral formula per day. Immune nutrition should not be used. Immune modulating nutrients could be considered for patients in traumatic brain injury and perioperative patients in the surgical ICU. Glutamine is not recommended in critically ill patients with multiple organ failure. So I hope this talk was very useful and helpful. Thanks for patient listening. More in my next lecture. Until then, goodbye, take care. This is Colonel Pradeep Pendiala, Professor of Anesthesiology, signing off for tonight. Bye-bye.